about chordomas are in this slide. The only two good things. They are rare, and they are even more rare in children. And I will tell you why. Because chordoma, to understand the chordoma, we have to get rid of old ideas, of old concepts. That chordomas is, because chordomas most of the times have a low mitotic activity, and they grow slow, they were to believed to be benign tumors with malignant behavior. This is not true. Chordomas are malignant disease. Chordoma is a cancer because they invade the tissue locally, they metastasize, and they implant. If you are operating a chordoma and you have chordoma cells in the muscle, in the skin, it can grow a new chordoma there. Chordomas have the ability to progress. They can progress to more malignant forms. Even if you do not do any treatment, they can mutate and they can accumulate mutations, becoming more malignant. They can grow into many sizes. They can invade different anatomical compartments. They can compress the brainstem. They can go to the foramen magnum. They can erode, and they do erode the bone, leading often to cervical instability. So the condyles are often involved. The current treatment for chordoma is maximal removal and radiation. Radiation is part of the treatment. Radiation is not an option. You have to give radiation after you remove a chordoma. But to understand how to treat, how to operate the chordoma, you have to understand how the chordoma behave. Chordomas are like termites eating the wood. Chordoma eat the bone and infiltrating the bone. And even when you think you have reached normal bone, there is still some islands of tumor spread in the middle of the normal bone. And that is why you need radiation. The best radiation modality for chordomas is proton beam, not because of the efficacy of the radiation, but because proton beam allows you to give a higher dose with less morbidity. If you don't have proton beam, you have to give what you have. You have to give radiation to all chordomas after you remove it. Even when it's even in children, people are often scared of doing big surgeries and radiating children, but for children with chordoma, you have to give them radiation. The difference when you remove all the tumor and give radiation, when you compare, when you remove just part of the tumor, is enormous. This is gross total resection. This is subtotal resection. But to understand how to operate on the chordoma, you have to understand where the chordoma is growing. And chordomas are extradural. They grow extradural. They grow from the bone. So you need an extradural approach. So think of the chordoma as this star in the middle of the clivus. They can grow anterior to the anterior skull base, to the sellar region, towards the cavernous sinus. They can grow laterally to the petrous apex. They can go posteriorly to the foramen magnum and to the occipital condyles. So how are we going to reach them? Well, if they're in the midline, you can use anterior approaches. If they are growing laterally, anterior and laterally, you have to use an anterolateral approach. If they go laterally but posteriorly to the condyles, you use a posterolateral approach. What happens many times is you're going to need more than one approach or combine approaches to get maximal resection. There's this paper of Dr. Borba and Al-Mefti. They describe the number of anatomical areas compromised to have an idea how many approaches you might need. So, for tumors in the midline, we're going to use anterior approaches. The tumors in the midline, they are limited by the internal carotid arteries. If they are extending laterally to the carotid, if it's a mild extension, you might maybe reach them by an anterior approach. But if there is too much tumor lateral to the carotid, you're probably going to need to associate other approach. The approach that we most of the times use, the anterior approach that we most use for the chordomas is the classic transsphenoidal. It doesn't matter if you go with the microscope, it doesn't matter if you go with the endoscope. What matters is you get the patient what he needs with the same morbidity. So if you can remove all the tumor, all the compromised bone, you can use the technique that you're trained to do. So for lesions in the superior third of the clivus with no or minimal extension lateral to the carotid, you can use the transsphenoidal approach. It's good because you can do the nasoseptal flap, which is very important for reconstruction. You have a good vascularized flap. The cosmetic result is very good, but it works for selected cases. The approach that we most do is the extended transsphenoidal. It was described by Dr. Al-Mefti as the anterior clivectomy. It's the same classic transsphenoidal, sublabial classic transsphenoidal, but with a unilateral maxillotomy. This way you can reach lateral extensions and allows you to work with the endoscope and the microscope. So this is how we do. This is a cadaveric demonstration. We do a unilateral maxillotomy and expose the whole clivus. And you can use the microscope and you can use the endoscope. This is an example. Here we are in the clivus, we're drilling, we're removing the bone. You can see that the bone is different. The bone is a thick bone. As we drill the bone, we start to see tumor coming out. We're going to start reaching the soft part of the tumor, see? The soft part is easy because it's very like a jelly. The difficult part is to remove the bone which is compromised. It's not difficult to remove the bone, it's difficult to know when to stop removing the bone, because the more you drill, the more thick bone you find. This is the intradural part. This was the way that the chordoma was going inside the dura. We can put our endoscope there and see if there's still tumor in the intradural compartment. We can check with the endoscope, see if there's any tumor left behind, and then we reconstruct. Usually we use fascia lata, nasal septal flap, and you can put fat, abdominal fat, and glue. This is how it looks. We're still trying to find a way to reconstruct the skull base. This is a project we did in the lab. This is it's a flap made with the 3D printer. It's customized for each patient based on the navigation. But until now, we don't have any type of product that will close the bone defect in the skull base when you do an anterior approach. Transoral approaches only for very selected cases, lesions on the upper spine, retropharyngeal, especially for extradural lesions. Not very good if you have intradural invasion because there is a high risk of contamination, meningitis. The transmaxillary approach, we're not using this, but some people are still using. It's very difficult to reconstruct. You have to put all the plates, you have to put the screws before to measure, to make a very symmetric reconstruction. So when you have extension to the anterolateral aspect of the skull base, we're going to use anterolateral approaches. And the one we use is the middle fossa approach, like we did in the lab, the middle fossa peeling everything extradural unless you have intradural invasion. You can reach the cavernous sinus, the petrous apex. You can remove the petrous apex if he's still there, because most of the time the tumor already destroyed the apex, and you can reach the posterior fossa. It's the same approach we saw yesterday, middle fossa peeling, and the tumor will be invading here. Here's an example. This is the left side. We are cutting the middle meningeal. We're going to find the middle meningeal, cut the middle meningeal. And when we start peeling the middle fossa, we're going to see tumor coming out right underneath V3. This is V3. This is tumor. See? No bone here. The tumor already ate the bone. So right underneath V3, tumor coming out. The tumor ate all the middle fossa, all the floor of the middle fossa. And here, this is posterior fossa. This is tumor in the posterior fossa. This is, I'll show you again, but we saw GSPN was hanging here. So we keep drilling all the clival bone, and you can also put your endoscope here in the posterior fossa to see if there is any tumor left. When you have posterior extension, you can use posterolateral approaches. You saw today, there's one going on in the OR right now, and it's the transcondylar approach. Dr. Barber is doing one right now for a chondrosarcoma. So the transcondylar is a lateral approach, it's a straight shot to the condyle. You can remove lesions like this. You can go all the way to the odontoid process if you need, to the retropharyngeal area. We do in lateral position. Some people put patient in dorsal position and rotate the head. It depends on the preference of the surgeon. So you saw the demonstration today. When we do this approach for intradural lesions, we put the sternomastoid anteriorly and the splenocapitis posteriorly. When we do for extradural lesions, we detach the two muscles together and retract posteriorly, both of them, like you see here. We mobilize the vertebral artery. We open the foramen transversalis and mobilize the vertebral artery for all cases. This is a demonstration. I'm going to fast a little bit forward so don't waste too much time. This is opening the foramen to transpose the vertebral artery. Forward a little bit. Okay. So this is dissecting the artery. We always dissect the artery like this. We do not dissect the artery like for anatomy. The artery is always kept inside this aureolar tissue, which contains a very dense venous plexus. They describe like the suboccipital cavernous sinus. So if you try to dissect the artery like anatomical demonstration, it will bleed a lot. So we always keep this tissue around the artery. You can place a stitch on this tissue and retract, so you don't go around the artery with the vessel loop. And then you start drilling the condyle. When you start drilling the condyle, you're going to see tumor coming out. See? So you can remove all the tumor, and you have to drill all this bone around. You can also use your endoscope here to check if you have intradural involvement. Closure is in the same way. We use fascia lata. You can use glue, and you can use the flap, the same flap we did yesterday, the flap with the fascia of the posterior aspect of the temporalis muscle. You can use that fascia to close the defect on the temporal bone and the junction. Sometimes you need to fix the spine. Sometimes the chordoma it caused the defect. Sometimes you cause the defect when you drill the involved bone. The important thing is to make sure the patient is stable. You can do in the surgical at the same time of the surgery. You can do some in different time, but you have to make sure the patient is stable. Dr. Borba made this, he calls the rule of 10. This is how you should face a chordoma case. So I'm going to read this to you. So the tumor is extradural, then you should use an extradural approach, as we saw. So you have to go where the tumor is growing. You have to explain to the patient and to the family that probably you're going to need more than one surgery to get the maximal resection. The more tumor you remove, more success you have to get the patient to live without the tumor. And better will be radiation. The less tumor you have to radiate, more effective will be radiation. And maximal resection means not only the soft part, but also the compromised bone and some of the normal bone. And that doesn't mean that we're going to give more mobility to the patient if you do a maximal resection. The endoscope, you should use the endoscope in all cases, combined with the microscope to get the most you need. Navigation is good to localize the tumor island that are spread along the bone. So sometimes it's good to have the bony window on the navigation so you can see where the tumor is in the bone. And that's the importance of the CT scan. The recurrence is directly related for the first time you try to remove the tumor. So the best time to get the tumor out is in your first surgery. So your first surgery must be for total maximal removal. And be sure to follow the patient very close because he will probably recur, and when that happens, you have to give him treatment again. So chordoma is a cancer, and you should treat it that way. So if you see a patient with a small chordoma, don't wait. Take it out. The first time is the best chance you have. And maybe you're going to have to operate that patient again. In concern to the surgical approaches, the best approach is the one that will give your patient what he needs. So if you can offer that with the endoscope or the microscope or whatever technique you have, if you can get what the patient needs with the same morbidity, you should use the technique that you know how to use. We cannot lose our hope with chordomas. We still don't have a cure, but we have to make every effort to make the patient live well. Thank you.
Большое спасибо за презентацию. Напоминаю, что вы можете задать свои вопросы, интересующие вас. Если нет вопросов, то приглашаем следующего спикера, Артур Николата. Есть все-таки вопросы? There are some questions, so can you could you please return back? Yeah, there are. No, I haven't seen two, so it's okay.
The question is that if there is difference between the cranial chordoma and the spinal chordoma, because most of the time we come across with the chordoma at the sacral area. So is the nature and the pathology which you are describing is the same for both, or these are two different entities? The clival chordoma and the sacral chordoma.
And what chordoma?
Sacral chordoma.
Sacral?
Yes.
Oh, it's different. It's the same chordoma, but the treatment for the sacral chordoma, you can be more aggressive than in the skull base. I mean, you can remove more bone. So you can offer a more aggressive surgery than when the tumor is growing in the base of the skull. But the treatment is the same. Is to remove the more you can get and radiate.
Pathophysiology is same. Means the pathophysiology and the behavior of the tumor is same.
The behavior is the same.
Any other questions? Есть еще вопросы? Тогда приглашаем следующего спикера Артур Николаеву с лекцией «Отработка нейрохирургических навыков на гибридных моделях». Давайте поддержим.
At first, I thank Professor Sufyanov and his great team for this learning opportunity, and again for the insuperable Siberian hospitality. And thank Professor Borba, President of our Brazilian Society of Neurosurgery, great surgeon and enthusiastic of neurosurgical education. My name is Arthur Nicolato. I'm a neurosurgeon in Belo Horizonte, and I will talk about ways to improve microsurgical skills using hybrid models. In Belo Horizonte, I work in the Metropolitan Hospital, a new public hospital with 500 beds, 50 dedicated to neurosurgery and neurology. And at the Federal University of Minas Gerais School of Medicine, where we have our simulation laboratory. Surgery is a very complex science that requires intensive dedication. The importance of organized formation for surgeons or neurosurgeons is not a new idea. Professor Halsted established the first fundamentals for medical training in a residence system based in the principle of methodical following experienced professionals. Professor Yazargil, father of the modern neurosurgeon, elected Man of the Century in 1999, say in that year, "The quintessence of my 33-year-long mission has been to convince my neurosurgical colleagues of the absolute necessity of laboratory training in microtechniques before their application to humans in the operation room." What happens after 2 decades? High-profile patient safety incidents have been a primary driver for increasing focus on patient safety, accountability, and surgical performance. The introduction of reduced working hours for doctors in training was an attempt to improve the working conditions of residents and, ultimately, patient safety. It increased the need of high-quality, time-effective training to surgeons to ensure optimal patient outcomes. And the solution is laboratory simulation. Anatomy is the most fundamental knowledge for a neurosurgeon. Cadaveric specimen is a great instrument for this kind of study, but the conservation techniques change the consistency, resistance, and aspects of the tissues, making limits for the applicability for microsurgery. The access to this material is not universal too, and occurs generally in reference labs like here in Tumen. Beautiful specimens like this, made by Professor Cassius Reis, are excellent for learning surgical anatomy, but the dissection of a sylvian fissure or a tumor dissection or how to clip an aneurysm can't be well represented in this kind of material. Many attempts to change cadaver introducing synthetic parts to use them in microsurgery simulation was made. In this hybrid model, for example, haptics still remains far distant from the real sensation of operating a patient, and the cost and the access of a cadaveric material limit the reproducibility. This is another example of cadaveric modification. It has the same limitations, but the infusion makes a great difference in the content of this specific model, more useful in our opinion. Another easily possibility, conventional animal parts as chicken and turkey wings are cheap, safe, and very acceptable in the modern ethical principles, but the applicability are limited for gross techniques and not permit simulation of specific neurosurgical procedures. Alive animals are excellent models. In them, it's possible to perform some microsurgical procedures as microanastomosis and microdissection of vessels, but the anatomical and size difference limits this model for neurosurgical procedures. And nowadays, we have many problems in use alive animals for surgical simulation because the ethical protocols become more and more rigid in the regulation of this kind of practice. In the last years, especially in North America, many virtual systems are introduced to complement residence formation. Here's an example, the NeuroTouch, made by the McGill team. This amazing technology permits a great experience, but remains very expensive and have limited capacity to simulate haptics involved in surgical procedures. In 2007, I was testing some silicone solutions to perform head injections, and I damaged one valuable specimen and decided to use placentas to train solutions. In that time, Professor Marcelo Magaldi see our tests and become interested in use this material to make models for training our residents. After 5 years of work, we have our first publication. 2 years ago, Professor Guzmão, emeritus professor of our department, showed our model to Professor Yazagil, and his opinion made us very proud and confident to continue our work. The video. We don't have the sound, but you can read. Unfortunately. In this model, it's very important the simplicity and reproducibility. We take the placentas from the university maternity. As guaranteed by Brazilian Health Ministry protocol, all the women are tested for infectious disease before the delivery. In the lab, we remove the external clots and parts of the amniotic membrane and cannulate with nalaton catheter the vein and the 2 arteries. After that, we irrigate with water, removing thrombs and clots, making all the vascular tree free for posterior special perfusion. This is how one prepared placenta looks like. In this condition, the placenta can be conserved during 4 or 5 days under refrigeration between 2 and 5 Celsius degrees. It's very simple to create a small neck aneurysm in this model. We only need to find a trifurcation and close one arterial segment with a simple suture. To make a large neck aneurysm, we use a neonatal size Foley catheter. We put the catheter inside one artery and navigate it to a trifurcation where we insufflate the cuff, breaking the muscular layer of the artery. During the perfusion, the fragility made by this maneuver causes the dilatation similar to a large neck aneurysm. As we see in this photo, here with the catheter cuff and here the aneurysm result. To perform more complex exercise, we overlap two placentas, one with blue perfusion solution and another with red perfusion solution, make different venous and arterial levels. The perfusion solutions are quite simple to prepare. We just use aqueous and atoxical ink and aspirin to grow the solubility and insert with a syringe into bottles that can be easily connected to the catheter that we insert in the placenta vessels before. Here is an example of large neck aneurysm dissection exercise. It's our Sylvian fissure. And our 30-year resident is doing this exercise. It bleeds, and it can coagulate with a bipolar forceps. The coagulation was provided by the retraction of the tissue. Now he can look for the aneurysm. He found it. Dissecate like arachnoid. Here's the lesion. Ready to be clipped. Now we open the aneurysm to show how it bleeds. The model is not useful only for vascular surgery. In this publication, we show how to simulate tumor resection using silicone inserted with a needle into the placenta stroma. Silicone infiltrates around small vessels that bleed during the tumor resection. Hemostasia can be performed with bipolar that causes retraction of the vessels. We also can simulate neuroradiology procedure using placenta, and we are working in validation of these models as tools to optimize surgical abilities. In this other publication, we show how it's possible to simulate endarterectomy using bovine placenta vessels. Here we see how this vessel can be similar to common internal and external carotid arteries, having even a thyroid branch. We can simulate arterial stenosis using polyurethane with silica injected into the vessel. Here is our first hybrid model with 3D printed skull and placenta combined. This first hybrid model is especially useful for bypass exercises. In this video, we simulate a bypass with superficial temporal artery to middle cerebral artery. Dissecate the sylvian fissure, find the middle cerebral artery, and perform the anastomosis. We continue improving the model because human placenta is still as a very special material. Despite it's easily to obtain in certain hospitals, the availability is not universal, and this material represents important limitation for reproducibility of our model. Another problem is the low quality of representation of the gross anatomy. Another portion that needs improvement is how to control fluid circulation. For the most simple model is okay for conventional microsurgery procedures, but is not enough good for intra-arterial navigation. The challenge is how to maintain low cost and make possible to do better. Now we are using Carova placenta. We start to use bovine placentas during the environment of our carotid endarterectomy model. The cost is low, the material is safe, and in Brazil it receives the same treatment of bovine meat. It means that it's possible to prepare, transport, and commercialize if sanitary protocols are respected. Here is an example of a bovine arterial segment prepared to represent the femoral artery. To reaffirm the low cost of the entire model, all the anatomical gross representation use the structure of a simple commercial mannequin, easily found in any place, with modification too easily to be made by anyone. To simplify the reproducibility, now in Brazil is also available to buy already prepared bovine vascular material made for this Brazilian company. Another useful resource is this skin-like biological material made with bovine uterine wall that improves the mannequin appearance. To improve the irrigation, we add one perfusion system similar of this developed and published by Miller in 2013. We just substitute these silicone tubes with real vessels. To simulate the subcutaneous tissue, we use cheap conductive gel. Here's an example of arterial puncture with ultrasound registration using the model. And here, a Doppler image of the perfused vessel. With this improvement, it's possible now to perform an entire angiography, identifying lesions before clipping, and eventually embolizing an aneurysm or placing a stent. Here, Professor Colley is showing to students how to perform microsurgery using our model during an event of Brazilian Society of Neurosurgery. In truth, it's a very special way to invite young doctors to dedicate themselves to a microsurgical life. These medicine students are learning with one of the greatest neurosurgeons of the world, and we hope that some of those kids understand that continuous process and that they can continue their training at home with simple models, constancy and dedication. This is part of our team in Belo Horizonte. I thank everyone for attention, and again, Professor Sufianov and Professor Boba for this great opportunity.
Thank you for your presentation. Спасибо за презентацию. И если у вас есть какие-то вопросы, задавайте. Here's
Thank you for the presentation. I don't know what you think about some models. In America, in Australia, I saw this year, they made some vascular models with 3D printer. And they use, and a company, England company, they use three kinds of synthetic plastic model and very different material. They print with silicone and plastic, and another kind of plastic, ABS, and they have very good example of aneurysma for clipping and from tumor resection.
Yes, I know these artificial models are very interesting too, but it's not real biological tissue, and it's more expensive than this model. The idea of this model is you can make everything in your service and in your hospital. You don't need to buy something. It's a model for the third world, for any interested can train microsurgery.
But for example, right now I am working in the UNESCO Anatomy Committee, and we're working, trying to develop new technique for 3D printer to teach anatomy and try to get a very low cost. I am from Dominican Republic, and
it's a perfect initiative.
We don't have so much possibilities to get the cadaver to training. It's not allowed. There is no way out there. Also, buy some models from companies like I told you, or 3B company, the German one. It's very expensive, 1,000 euros, 2,000 euros. So I don't know if you work with the 3D printer maybe in your hospital.
No, I have no access to 3D printer in our hospital, but all these techniques improve the training around the world, are good initiatives.
Thank you.
Thank you.
I have one question.
Thank you for your presentation. It was really great and very informative. So first of all, I'd like to ask legality of using the placenta in each country, in your country especially. Like we would like to try it here, but it's a little bit hard to get permission from the hospital, placentas, and legally or what?
It's legal. The way is submit the use to ethical committee of the institution, and in Brazil all the placentas are donated by the mother before the delivery. The women sign on term of donation, and we after the delivery we catch the placenta and use in the lab, and we maintain the terms of donation with our in our lab.
Oh, okay, yes, thank you. I got it. Thank you so
And
much.
the bovine placenta don't need anything.
So,
Just buy.
Every woman like gets permission. Like, is there any?
It's very easy. We made one
Was it
form
easy? Yeah.
that clarified
Ah.
the use.
So you get the agreement of
Agreement,
the yes.
yes.
from the pregnant women, and then you just get the placenta, and that's all. Yeah?
Yes.
So
Okay, thank you. Thank you so much.
so I have a question. Maybe I missed this information in the presentation, but how long can it be used? I mean,
After preparation, the placenta can be used for 4-5 days. After that, the consistency changes and is not a good model.
thank you.
You know.
Еще вопросы? Any other questions? Если нет вопросов, то давайте поблагодарим нашего спикера. И следующий докладчик Абидха Ша с темой по платибазии. Давайте поприветствуем.
So good evening, everybody. We've been talking a lot about craniocervical junction and the far lateral approach and the transcondylar approach. Let's go further down to the C1, C2 region and to this entity of basilar invagination. Mind you, this basilar invagination has come into our realms of treatment very recently. Up till a few years ago, no one knew what this was and no one knew how to treat it. I'm just going to show you an evolution of the management of basilar invagination and where we are today. So these were the first accounts of basilar invagination. It was observed by Ackermann in 1790 in cretins, and he thought it was a disease of cretins. But later on, it was found in other populations also. In 1855, Anders Retzius and Berg called this impressio basios cranii, and this is the term we all became familiar with as basilar invagination. Furkow, in 1857, first defined platybasia as an abnormal flattening of the base of the skull. They found basilar invagination to be associated with platybasia in a very huge percentage of cases. So the terms started being used interchangeably for a long time. However, it was later redefined as platybasia was an abnormal flattening of the base of the skull, as we saw earlier. This is platybasia. It may or may not be associated with basilar invagination, but most of the times it is. And basilar invagination was defined as prolapse of the vertebral column into the skull base. As you can see here, the odontoid has gone up above this line, as you can see in this image. And also this is basilar invagination, where you can see that it has not crossed the Wackenheim's line, but it has crossed the Chamberlain's line, and it is way above the heart palate. and this is also basilar invagination. So this was an old picture where the interior of the skull had been removed, and you could see the projection, the cephalic bulge of the clivus, and the stenosis of the foramen magnum, as was seen in cases with basilar invagination. So this is the very initial first paper where Chamberlain defined basilar invagination as, it is as though the weight of the head has caused the ears to approach the shoulders, while the cervical spine, refusing to be shortened, has pushed the floor of the posterior fossa upward into the brain space. The first case was diagnosed radiologically in 1911, but for a long, long time, they just remained as anatomic and radiologic curiosities. These were a variety of lines that were defined by radiological diagnosis, but still there was no treatment for this entity. Earlier anatomists thought that the reason for basilar invagination was mechanical. However, all the later people thought that it is due to a developmental anomaly of the bone. However, they also realized that this developmental theory failed to explain the late neurological deterioration that occurs in these patients. They may be well when they are young, and they deteriorate only as they grow. At this time, basilar invagination was divided into primary and secondary. Primary was believed to be due to a defect in craniovertebral development, and this was due to diseases where there was a softening of bones like Paget's, rickets, etc. What was the early treatment options that they had? In 1939, Chamberlain treated 2 patients with suboccipital decompression and upper cervical laminectomy. What happened? One patient survived with not much improvement, and the other one died within a week. The treatment at that time was exclusively surgical, and this was the modality, suboccipital decompression with upper cervical laminectomy. Though many surgeons followed them, the results were variable. The associated morbidity and mortality remained very high. So these are some of the early papers with results of treatment of basilar invagination with suboccipital decompression. So this is another paper where one of the authors suggested traction or the use of a supporting apparatus for the head or neck for the treatment of basilar invagination. This is one of the first papers which mentions this kind of treatment for this. However, the dilemma was still on with no defined treatment for this condition. This is the treatment modality that was recommended by Phillips. He either said you immobilize the patient, you give traction, or at the last resort, they tried surgical decompression, again with variable results. So in 1964, our department is a large referral center, and in India, somehow we see a lot of these patients. So we started working on this entity of basilar invagination, and this was where the research started. It was found that after suboccipital decompression, there was a sudden hematomylia and respiratory arrest developing at open surgery for release of pressure on the medullospinal tissues or as a postoperative catastrophe. And they thought that this might be the reason of deterioration after surgery for basilar invagination. Then came this paper in 1980, where Menezes had his algorithm, where he said that if there were reducible craniovertebral anomalies by traction, you just go ahead and do a posterior fixation. If there is an irreducible anomaly, if there's a ventral encroachment, you do transoral surgery with or without fixation. If there's a dorsal encroachment, you do a posterior decompression with or without fixation. This is where we stood in 1980. And there were a lot of methods of posterior fixation that came into vogue in this time. As you can see, there was the Galli's technique, the Brooks technique. Then transoral surgery came into vogue, and there were a lot of workshops of transoral surgery. They started introducing screws. Then there was occipital cervical fixation, which is still there. Of course, it is more better than this, but these were the earlier ways of doing it. This is the modern way of doing it with lots of rods and plates and everything. In 1986, Magarel came up with a technique of doing C1, C2 fixation by using transarticular screws. In 1987, 1988, Dr. Goyal came up with this technique of lateral mass plate and screw fixation for the C1, C2 region. And this was the technique. There was a opening of the joint. There was denuding of the articular cartilage. There was stuffing of the joint with bone chips. And then there was a direct application of screw to the lateral mass of atlas and to the pedicle of C2. So this was a more direct and firm method of fixation of the C1, C2 region. So this was the earliest patient in which this surgery was performed. As the as we progressed, in 1988, we published a paper where basilar invagination was divided into two groups based on the presence or absence of Chiari malformation. Even at this time, it was thought that basilar invagination is a fixed anomaly. So group 1 was basilar invagination without any Chiari malformation, and group 2 was basilar invagination with Chiari malformation. So this was the paper that was published at that time, and this was the treatment that was recommended. For group 1, that is without any Chiari malformation, we did a suggested that there was a direct compression of the brainstem by the odontoid, and a transoral surgery was advocated with or without fixation. For group 2, it was thought there is a reduction in the posterior cranial fossa volume, and we advocated a posterior fossa decompression. But still, we found that the results remained variable. Some patients continued to not do well even after this form of treatment. So the treatment was based on it being a developmental anomaly with a small posterior fossa and Chiari malformation. The entity of basilar invagination still remained an enigma because the results continued to be variable. Then came this paper in 2004, where basilar invagination was again redivided, not on the basis of Chiari malformation, but on the basis of this. The prolapse of the odontoid into the skull base, crossing the Wackenheim's and the Chamberlain's line, was called as group A, and group B was when the whole system moved up above the Chamberlain's line. The odontoid did not cross across the Wackenheim's line. This was called as group B. It was noticed in group A that these were the kind of joints that you saw in the C1, C2 region. The joints were abnormally inclined. They were not fixed. They were mobile or hypermobile, and mechanical instability was postulated to be the cause of basilar invagination. This was likened to a lumbosacral listhesis, where the facet of atlas moves ahead of the facet of axis. And this explained the late deterioration in patients where the facets moved ahead as the patient grew older. And this was the technique that was published, where there was a distraction of the C1, C2 joint with the use of either bone graft or metal spacers, followed by a C1, C2 fixation. And this revolutionized the treatment of basilar invagination and brought us to this present era of craniovertebral realignment for basilar invagination. And these are some of our results. You can see the severe basilar invagination. You can see the torticollis in this patient. This is post-surgery, just posterior surgery, no decompression, no transoral. You can see the reduction, you can see the fixation, and the reversal of the torticollis. This is another patient where you can see the severe basilar invagination, just posterior reduction, and you can see the craniovertebral realignment and the fixation. While doing this study, we noticed that immediately after surgery, there was a reversal of long-standing musculoskeletal changes in basilar invagination after C1, C2 fixation. The changes we observed was a change in torticollis in the length of the neck. The neck increased in size after surgery. As you can see here, you can see this patient boy, he had a torticollis and a short neck, little bit short neck, and you can see this is immediately after surgery. Within 2 to 3 days, the torticollis has reversed, the neck has lengthened. And this is the basilar invagination, and you can see the craniovertebral realignment. You can see this other patient with torticollis who was looking to this side. He said after surgery that I did not see my doctor earlier, but after surgery I'm actually able to see who has operated me. So this was the pre-op and the post-op of the patient. So these are a few examples of the basilar invagination. You can see how severe they are and how much they have prolapsed into the craniovertebral region. This is someone had operated earlier and done an occipitocervical fixation. We reoperated this patient and we did a craniovertebral realignment, and the patient did well. You can see the C1, C2 fixation. This is another patient with a very severe basilar invagination, just posterior surgery, distraction and fixation of the C1, C2 joints. This is another example of a C1, C2 fixation. This is also, you can see how the joints are inclined. They're absolutely prolapsed. When the atlas is in front of the axis, we call it spondyloptosis. It has absolutely fallen down. It is difficult to do these cases. There is a lot of problem because of the venous bleeding, because of the vertebral artery, and because of the anatomy of the joints. But as you start doing them, you become familiar with this anatomy and you're able to treat this. Now, group A basilar invagination also can have Chiari and syrinx, and you can see this is the pre-op. And after surgery, in the immediate post-operative period, you can see reversal of the Chiari and the syringomalia. This is another patient with Chiari, group A basilar invagination, and syrinx. This is again in the post-operative period. The Chiari has gone up, the syrinx has reduced, and you can see the fixation. This is another patient. Here you can see how abnormal the vertebral arteries are. This one is running right on the pedicle of C2, and this one is also coming close. When you start understanding this anatomy, you learn to mobilize the vertebral artery, and then you're able to do a good fixation. As we progressed further in the evolution of this treatment, it was realized that basilar invagination instability is the main cause of basilar invagination, not only for group A, but also for group B, where earlier we were doing a posterior fossa decompression. We now realize that that is not enough, and you need to do a C1, C2 fixation for good results. So this, we reclassified this facetal alignment to identify the instability, and you can see that here this is the classical facetal alignment of a group A basilar invagination where the atlas is in front of axis. This is another example of basilar invagination. This is group B, where you can see that the whole odontoid has moved up and the facets are posteriorly inclined. The atlas facet has moved posterior to the facet of axis. We call this as group B, type B. And then we have a type C where the facets are actually in alignment. This is again a type B. But we have realized that still the joints are unstable. There is craniovertebral instability. And we have started doing atlantoaxial fixation for group B basilar invagination. And I will show you some images. This is again group B. These are the most difficult basilar invaginations to treat surgically. The joint is extremely high. The occiput is in your way. But as you start treating this and you start understanding the anatomy, you are able to do this quite successfully. You can see the huge Chiari. You can see the basilar invagination and the fixation. This is another patient with Chiari in group B where we have done a fixation. And here you can see the Chiari, the syrinx. This was the pre-op. This was in the immediate post-operative period. And this was the delayed film. You can see that the Chiari has gone. The syrinx has reduced markedly. This is another patient with a huge group B basilar invagination, Chiari and syrinx. This is you can see that there is no change in the atlantodental interval. It's absolutely fine. But here the facets are also in alignment. This is type C. But when you see intraoperatively, it is quite immobile. You can see how high this is. This is the Chamberlain's line. This is where the odontoid has gone up. And you can see in the post-op, after a few months, the Chiari has reduced and the syrinx has reduced markedly. We also came up with this three-dimensional models for treating our patients with complex craniovertebral anomalies. This helps us to see the anatomy of the region and also to study the anatomy of the vertebral artery. So this is a patient where you think it is quite straightforward. There is a small basilar invagination. The facets are relatively okay. And we went ahead and did with the fixation. But we also had a model on this patient. This is our 3D CT, and this is the model. And you can see where the vertebral artery is going. It is going right on the facet of C1. So when you're inserting a screw here, when you're handling this area, there is a risk of damage to this artery. But when you have this in mind, you're aware of it and you avoid injury by mobilizing this artery upwards. This side artery is normal, so it's okay. And these models, believe me, they're very helpful. They're lying right next to you in the operating room. So you're operating on the C1, C2, you just look at the model if you have, and it's an absolute typical bony. You can actually make out the bony landmark. Okay, I'm here, or okay, I'm there. So they're very, very real-like. This is another patient, basilar invagination with some degenerative arthritis. And here you can see the model. Again, the artery is going abnormally like this. So in this situation, what we did was, this is the model, and you can see how real it feels like. On this side, we just put a C1, C2 spacer, and on the other side, we did a C1, C2 fixation, and the patient did quite well. Now, this comes to the last part of my lecture, where all the controversy arises. Chiari malformation. Everyone here must be treating Chiari malformation in 100 different ways. No one has a standard way of treating Chiari malformation. You might treat it differently, you might treat it differently. And everyone has their own protocol of doing this. But as we started seeing these cases of basilar and Chiari, we started handling them intraoperatively, and we realized that atlantoaxial instability is the cause of Chiari malformation. And this was our initial paper that was published in 2014. I will show you a few examples. This is the Chiari with a mild syrinx. This you can see here. This is a type B facetal malalignment. There is no atlantodental interval abnormality. This is post-operative. You can see there is no decompression, just a C1, C2 fixation. The Chiari has gone up. The syrinx has reduced. This is another patient with just Chiari malformation. There is no obvious bone anomaly. The atlantodental interval is normal. The facets are also relatively well aligned. We have just done a C1, C2 fixation. You can see the post-operative after 3 months of surgery. The syrinx has completely become very small, and the Chiari has gone up completely. This is another patient with a basilar invagination and Chiari with a huge syrinx, and this is the post-operative where you can see that the Chiari has gone up and the syrinx has reduced. Here you can see that the facets are, this is type B facetal malalignment. There is no change in the atlantodental interval. So there are many cases like this now where we see this. It does not matter if radiologically you might not see an improvement immediately. The clinically patient will improve. Radiologically the change comes. It comes after 3 months, 6 months to a year, but it definitely comes. This is another patient where you can see there is just Chiari. There is no basilar invagination. There is a huge syrinx. You can see the type B facetal instability, and you can see the post-operative. After a few months of surgery, Chiari has gone up, syrinx has reduced, patient doing extremely well. We also have used this treatment for pediatric patients, and there also we are getting very good results. Now what happens when your foramen magnum decompression fails? We have had our own patients who have come back to us after many years of surgery, maybe 10, 15 years of surgery, and we have reoperated them and done a C1, C2 fixation with very good results. So this is another patient who was operated outside with a decompression and a shunt, and you can see the syrinx, and the patient continued to deteriorate clinically. We do not see the radiology. If the patient deteriorates clinically, we go ahead and reoperate and do a C1, C2 fixation, and you can see the results. So basilar invagination, syringomyelia, and Chiari malformation are all a spectrum. They all have their basis as atlantoaxial instability. Chiari is a protective malformation that stalls or delays the effects of instability. This is a recent paper that we published where we checked the transcranial MEPs before and after fixation. So this was a patient with basilar invagination, with just Chiari malformation, hardly any change in the atlantodental interval. This is the fixation. This is the preoperative MRI, and this is immediately after fixation we have done a transcranial MEP, and you can see the change in the motor evake potentials here. This is another patient with just Chiari and syrinx, and you can see there is hardly any transcranial motor evoke potentials in the preoperative period, immediately before the fixation, and after the fixation you can see the immediate change in the recovery. There is absolute recovery of the transcranial MEPs, and this improvement in the patient continues to occur. So this was a recent paper that we've just published last year. So basically, is Chiari malformation an airbag? When you have instability, when you have an accident, the airbag comes and protects you. For a limited period of time, you're going to improve. You have saved your life. But but you've lost your airbag. So the effects of instability continue, and they may manifest after a few years when they come back to you with a failed foramen magnum decompression. Basically, is it a formation or is it a malformation? Should we be calling it a malformation, or should we be calling it a formation? And does foramen magnum decompression surgery have a role, and will it become historical? So as the understanding of basilar invagination has evolved, it appears that mechanical instability is the cause, and craniovertebral realignment and atlantoaxial fixation is the current management of this anomaly. So the future is atlantoaxial stabilization. We do not do occipitocervical fixation. We don't think it is necessary. Foramen magnum decompression is counterproductive, and transoral, transnasal decompressive surgery are historical for basilar invagination. Thank you very much.
Thank you so much for presentation. Тут вопрос. There's one question.
Thank you very much. This is a very interesting presentation. I really enjoyed it. I have a few questions. Number one, you mentioned about the traction. Is it correct? So when do you put them on traction? Is it after you decompress intraoperatively before the surgery? That's one question. The second question, how you justify doing a C1, C2 fusion for somebody who's really not having instability on imaging, and they will lose about 50% of their rotation, and there is no really solid evidence on that. So I feel it's a little bit, to me, it's a little bit overdone, but you're showing good results, which is very impressive.
Question number 3. Would you suggest that patient who have, sometimes we face patient who have syrinx, no obvious reason, we look up and down and there is no, especially in the cervical, up high in the cervical. And if the patient becoming symptomatic, shall we do shunt? Shall we fuse them, C1, C2? I don't know the answer, so it's 3 questions.
Okay, for your first question, traction we give immediately after inducing the patient. After we put in the tube, patient is put on traction, and on traction we give position to the patient. The traction remains during the period of surgery, and once we make the patient supine, the traction is removed. It is just to stabilize the head and to give a little traction. The main step of the operation is when you insert the osteotome into the C1, C2 joint and distract it. That is the main distraction that is happening. After that, we insert bone chips into the joint. If you feel, you may insert a spacer, but as the time has gone on, we are okay with just using C1, C2. We are just okay with using bone chips. We have reduced our use of spacers. We do use them occasionally. So that is one. Second is Chiari. We are getting such fabulous results. Clinical, radiological comes data, but we are getting such fabulous clinical results that it is difficult for us to go back to foramen magnum decompression. We have been doing foramen magnum decompression till a few years back, till maybe 2008 or 9. But our patients keep coming back to us, and we have realized that they're doing very well with C1, C2 fixation. Now we have a longer follow-up, and we are very happy with the results. That's why we are able to justify doing a C1, C2 fixation. And I forgot your third question.
Syrinx, up high cervical syrinx.
Idiopathic syrinx, idiopathic syrinx, yes.
Symptomatic.
Yes, I actually removed that paper. We have a paper on that also, treatment of idiopathic syringomyelia. Yes, you can try a C1, C2 fixation. They do improve after that.
Еще вопросы? Any other questions?
That case, we have Chiari 0, in that classification, that we don't have any invagination. Do we have to take the odontoid out transoral or by the nose, or just fixation is enough?
Just fixation is enough. What you do is when you are operating, you try to distract the C1, C2 joints. Don't overdo it, as much as easily possible, and you put in the bone spacers, and in that distracted position you fix the C1, C2 joint. See, it is like this. It comes back. The odontoid comes back. Even if it does not come back completely, maybe there is something left. If the patient clinically is doing well on your follow-up, don't do anything, because this will fuse, the instability goes away, the improvement sustains. If there are very few cases that I have seen, actually I have just seen 1 or 2, and it is not because of the alignment of the odontoid, is because maybe the stabilization is not good. Maybe the fusion has not happened. Then maybe you can consider a transoral.
Есть еще вопросы? Тогда поблагодарим нашего докладчика за такую увлекательную лекцию. Действительно очень интересно. И следующий спикер Пабло Переда. Его нет. Тогда следующая, уже завершающая лекция Бенедикто Окколи, лекция «Конвекситальные менингиомы». Давайте поприветствуем.
Once more, I thank Dr. Sofianov and Dr. Borba for the opportunity to participate in this course. I will present how we treat convex meningiomas with bone invasion and hyperostosis. I have no conflict of interest. Cushing and Eisenhardt called the convex meningioma one that lies free of attachment to a major sinus. Currently are also excluded from this group tumors that are attached to the skull base. Convex meningiomas comprise 17 to 34% of the intracranial meningiomas. These tumors constitute 19.6% of the meningiomas treated at our hospital. They were located mainly in the frontal and parietal convexity. Bone involvement is uncommon among globular meningiomas, and it can be destructive or hyperostotic. Bone destructions are unusual in the cranial valve and generally are related to aggressive and malignant meningiomas. Mild hyperostosis represented by enostosis, that means a convex internal protrusion in the center of the dural attachment, are the most frequent bone change observed among convex meningiomas. Despite its hard aspect and not obvious involvement by the tumor, they generally contain tumoral cells and should be removed as far as possible. Marked hyperostosis is not frequent, and the irregular bone is invaded by the subjacent tumor. We observed 12% of bone changes among our patients. This patient presents with a huge contrast-enhanced tumor placed in the frontotemporal convexity of the right cerebral hemisphere. The skull X-ray showed the need of erosion of the right temporal bone. The patient was operated on, and the histopathological diagnosis was a meningothelial meningioma, with focal area of anaplasia and a relatively high Ki-67. Histopathological examination of the bone showed infiltration by tumor. The postoperative CT, done 6 months later, showed no tumor. 3 years later, there was evidence of recurrence of the tumor in the posterior temporal region, progressively increased in size. At that time, the patient refused reoperation. 7 years later, a new MRI showed a large increase of the tumor. The patient was reoperated, and the tumor could be again macroscopically completely removed, and there was no change in the histopathological diagnosis. The postoperative CT scan and MRI performed 20 months later showed no tumor. This is an example of a large temporal convex tumor with an enostosis well delineated in the coronal view. The craniotomy was marked in the skin with a neuronavigator. The skin incision was stretched over the tumor, and the periosteum was dissected and preserved for reconstruction of the dura mater. The craniotomy was also marked on the bone over the tumor using the neuronavigator. The enostosis was restricted to the inner table, and it was drilled out of the normal bone. The dura mater was adhered to the bone and suffered some lacerations during bone displacement. The dura was opened around the tumor, and the tumor progressively separated from the brain. The resected dura mater was replaced by a free flap of pericranium, and the bone was replaced. The histopathological diagnosis was an anaplastic meningioma with areas of focal atypia and Ki-67 higher than 5, and with mitosis. The hyperostotic bone flap was examined and revealed to be infiltrated by tumor. The MRI performed 6 months later showed complete resection of the tumor. This patient presents with a tumor in the parietal convexity with an enostosis. After the dural incision, the tumor protruded out of the dura due to the intracranial hypertension, and was gently separated from the brain and displaced upward and laterally. Because the tumor had a large base of dural implantation, it could be removed and blocked. The dural defect was covered with pericranial flap. The histopathological diagnosis was a meningothelial meningioma, and the MRI performed 4 years later showed no tumor. This RCT image of a patient with an occipital convex tumor suggestive of a meningioma with a hyperostosis of the occipital bone indenting the tumor. The MRI showed an indentation of the tumor through the occipital bone. During surgery, it was found the hyperostosis completely adhered to the dura mater, and the dura have to be removed with the bone. The exposed tumor was completely removed using microsurgical technique. The histopathological diagnosis was a fibrous meningioma. The MRI performed 2 years later showed no tumor. This patient was admitted with a protrusion of the frontal region starting a long time ago. The skull X-ray and the CT scan showed a marked hyperostosis protruding out of the frontal bone, with a contrast-enhancing mass over the left frontal lobe with marked edema of the subjacent brain. The MRI confirmed the bone changes and revealed the dural attachment of the intracranial tumor and the presence of a dural tail, suggesting the diagnosis of a hyperostotic meningioma. This is the aspect of the patient in the operating room. She was operated on in the spine position with the head extended and using a bicoronal flap. The pericranium was not invaded by the tumor and it was preserved for reconstruction of the dural defect. The craniotomy was performed using multiple boreholes around the posterior part of the tumor and using high-speed drill on the anterior part, preserving most part of the superior orbital ring. The dura mater was opened and the intracranial tumor was removed using microsurgical technique. The dural defect was closed with pericranium and the bone defect was closed with titanium meshes. And this was the final result. The histopathological diagnosis was a transitional meningioma. The MRI 8 months later showed no tumor. This patient presented with a tumor in the left frontal region that started to increase after a local trauma 4 months before. The skull X-ray revealed hyperostotic and lytic lesions invading the bone and protruding out of the left frontal region. The MRI showed an heterogeneous contrast-enhanced lesion invading the bone. After bone removal, the tumor was found adhered to the arachnoid and a microsurgical dissection with complete removal was performed with some difficulty. At a first impression, the histopathological diagnosis seemed to be a transitional meningioma, but an inflammatory infiltrate, not common in meningiomas, called the attention of the pathologists. They did immunohistochemistry tests that were positive for vimentin, excluding meningioma, and negative for CD34, excluding hemangiopericytoma. And the test was positive for 1A4 actin that stains myofibris diffusely in the tumor, indicate to be an inflammatory myofibroblastic tumor that is considered more a reactional growing after trauma than a neoplastic tissue. The postoperative CT showed no tumor. Hyperostosis on convex meningiomas occur with grades 1 and 2 tumors. Bone invasion or erosion generally occurs in atypical and anaplastic tumors. Convex meningiomas generally do not represent a challenge for being removed, but when they are accompanied by bone changes, technical difficulties as adherence to the dura mater and dura and bone reconstruction should be expected. And the recurrence of these tumors depends on the extent of the resection and on its histopathological grade. Thank you very much for your attention.
Большое спасибо за такой интересный доклад. И, как обычно, если есть вопросы, пожалуйста, задавайте. Не стесняйтесь. I have the question. So, Pablo Pereda is not here, yeah? No? Pablo Pereda? No? Not? Okay. So, thank you so much for your presentation. So,
Okay. Thank you.
now there's no questions. Так, это была самая последняя лекция. Что ж, теперь, наверное, предоставлю слово Альберту Акрамовичу Суфьянову. Давайте поаплодируем.
Let's give a hand to Mr. Sufyanov for the ceremony of awards.
Так, ну, время уже позднее, я так понимаю, работаем беспрерывно все эти дни.
It's late and we've been working for such a long time, for so many days running.
Вот, пришло время расставаться. Как
So
бы
it's
это
time to
печально
say
не было
goodbye,
сказано.
however saddening it is.
Вот, поэтому я думаю, что мы, наверное, приступим к церемонии вручения сертификатов.
So let's get down to the ceremony of awards.
Ну, несмотря на то, что у нас, конечно, профессор Борба в операционной еще. Борба и кто еще?
Professor Borber and some other professors are still in the,
Ну, я
doing
думаю,
the
там
surgery,
еще, наверное, долго будет. Нельзя
and I
узнать?
think it will take a long
Узнать нельзя в
time.
операционной?
Who else is in the surgery room?
Сергей, там узнает, долго-недолго.
Let's find out who's in.
Okay, I want one question. So 5 minutes rest or maybe continue with certificate process. Начнем, наверное, вручать-то? Okay? Continue. Валис Джалалов.
Хочу поблагодарить большое, сказать спасибо за этот замечательный курс. Хочу поблагодарить вас за этот замечательный курс, лекторов, вас, центр. Хотел пожелать удачи вашему центру и дальнейшее сотрудничество. Спасибо большое. Спасибо.
Адил Хусейн. From Peshawar, yeah?
I'm from Peshawar. Very much impressed with the facilities and the developments, and I thank you very much for inviting us. Thank you very much.
Thank you. Good luck. Сергей Ткачук. Сергей Ткачук. Нет? Наталья Степанова. Мубарик Акаева. Андрей Берсенев.
Берснев Андрей, город Екатеринбург, Уральский государственный медицинский университет, 6-й курс. Спасибо большое, профессор Альберт Акрамович, всему преподавательскому профессорскому составу, ординаторам. Замечательная возможность для нас, особенно для студентов. Вот, до встречи на Международной студенческой олимпиаде. Спасибо.
Сергей Парыгин. Иван Прохоров.
Иван Алексеевич, окончил военно-медицинскую академию города Санкт-Петербург, работаю нейрохирургом первый месяц в Городской областной больнице клинической. Спасибо большое центру за теплый прием, за такие замечательные доклады, дальнейшее сотрудничество и удачи вам всем.
Спасибо. Илья Зарихин. Илья Зарихин. Есть такой? Владимир Матвеев. Андрей Цигельник. Нелли Хайлеева. Нет, тоже нет. Ольга Борисова.
Врач-нейрохирург, областная больница номер 2, город Тюмень. Спасибо большое лекторам за очень интересные лекции и Альберту Акрамовичу за возможность участвовать в данном мастер-классе. Спасибо.
Анастасия Кафанова. Неправильно сказал.
Я ординатор второго года Тюменского медицинского университета. Спасибо большое, Альберт Акрамович, спасибо большое всему профессорскому составу за эту действительно очень интересную конференцию. Большое. Да. Жаль, конечно, что не поступила сюда в ординатуру. Ну что ж, все равно есть такая возможность послушать и даже поучаствовать.
Александр Теплоухов. Так, Али Мумтаз.
Thank you, everyone. I came from Peshawar, Pakistan. And of course, this was my second time in Russia. Particularly, I was concentrating on three things: the patient care, the research publication, and the teaching training. And I can see all these three segments, they are fulfilled under one roof. And I'm extremely thankful to Aliyah, Miss Aliyah, because she looked after my families. Particularly, you shared with me the idea of sending the trainee for the further training. So back home, probably, I will put this idea to the society, and hopefully, thank you very much, Mr. Sufyan.
Thank you. Thank you. Табита Казак. Question?
I am a third-year neurosurgical resident from Bucharest, Romania, and I want to thank all the professors from this course. It was a wonderful experience, full of everything. Workshop was really nice. We've learned a lot and hope to see you in the future.
Thank you. Иоанна Прикопий.
Thank you very much. I'm a second-year resident from Romania, and it was a wonderful experience, and I hope to be back here soon.
Thank you. Barrientos Evelyn. Barrientos, congratulations.
I'm from Dominican Republic, но я ординатор первый год в Москве. Я хочу сказать спасибо всем, спасибо профессор Суфьянов. Это очень интересная лекция. Спасибо.
Руслан Кадыров.
Кадыров Руслан, кафедра нейрохирургии, профессор кафедры нейрохирургии, Кыргызская государственная медицинская академия. Как все, что делается в этом центре, все на высоком уровне, Альберт Акрамович. Я очень рад, очень доволен. Все было круто.
Спасибо, удачи. Рамис Алимов.
Я из Санкт-Петербурга, работаю в детской городской больнице. Хочу сказать спасибо вам, Альберт Акрамович, за организацию этого учебного центра и проведение неоднократных мастер-классов. И спасибо нашим лекторам за то, что проделали такой путь, чтобы обучить нас и рассказать обо всем этом новом. Спасибо вам, Альберт Акрамович.
Спасибо. Александр Кормилец.
Александр Кормилец, город Омск, областная клиническая больница. Хочу сказать большое спасибо за прекрасный курс, за интересные доклады, прекрасный мастер-класс. Хочу сказать, что такой формат обучения не только дает новые знания, но и рождает в головах молодых нейрохирургов и профессионалов новые идеи. Спасибо большое.
Удачи. Юрий Кузьмиченко.
Кузьмищенко Юрий, Крым, Симферополь. Большое спасибо за прием. Я из солнечного Крыма думал, будет холодно, но у вас очень тепло. Тепло принимают во всех смыслах. Замечательный коллектив. Большое спасибо за все.
Айман Майдан.
Я с Казахстана, с города Алматы. Первый раз в России. Очень понравилось.
Организация супер, лаборатория еще лучше. Спасибо всем, что обучали, показывали. Спасибо вам.
Удачи. Максат Мусабеков. Матарули, да? Два слова.
Меня зовут Максат Мусабеков, я нейрохирург из Республики Казахстан, город Алмата, Центральная клиническая больница при управделами президента. Спасибо, Альберт Акрамович, спасибо лекторам, профессорскому составу, спасибо организаторам, все было очень высшем уровне. И спасибо специалистам, которые участвовали, помогали, показывали в мастер-классе. Огромное спасибо.
Елена Рыжкова. О, Москва пошла.
Меня зовут Елена Станиславовна Рыжкова, я из Москвы, нейрохирург, аспирант Института РДН. Большое спасибо за такой прекрасный мастер-класс. Программа достаточно насыщенная. Спасибо вам, всему профессорскому составу.
Удачи в защите диссертации. Марат Саржаев.
Тоже с Казахстана, с города Алматы. Работаю нейрохирургом в президентской клинике. Спасибо вам, Альберт Акрамович. Спасибо всем коллегам с рубежа, с Бразилии особенно. Вот, были прекрасные доклады, воркшоп, мастер-класс был плодотворным. Вот, то, что нужно для молодых нейрохирургов. Спасибо большое.
Удачи, спасибо. Я думаю, и не только для молодых, правильно? Булат Кинзигулов. Поздравления.
Булат Кинзигулов, ординатор второго года НМХЦ имени Пирогова, Москва. Хочу сказать спасибо огромное за организацию. И подобные курсы, это не первый курс мой. Здесь мирового класса курсы. И очень радостно, что у ординаторов в России и ближнего зарубежья есть возможность посещать такой курс. И спасибо вам еще раз. Спасибо.
Начальникам хорошо? Главному врачу Зуеву. Так, Александр Гагай. Наша старый боец, да? Поздравляем.
Меня зовут Александр Гагай, я из города Екатеринбурга, Уральского медицинского университета, 5-й курс. Хочу отметить то, что поучаствовав в этот раз самостоятельно в мастер-классе, понял, насколько это все-таки трудоемкий и серьезный процесс, которому нужно долго учиться. И сделал такой вывод, что в нейрохирургии, особенно в хирургии основания черепа, без таких мастер-классов вообще никак не обойтись. Хочу сказать огромное спасибо всем профессорам, лекторам, которые учили нас в течение этих 3 дней. И, как всегда, огромное спасибо всему федеральному центру и поклон.
Удачи. Ирина Боровикова. У нас, конечно, очень много участников.
Я студентка 6-го курса из города Екатеринбурга. Здесь уже не первый раз. И спасибо за теплый прием. Приятно возвращаться снова и снова.
Спасибо.
Мадина Бижева. Мадина победительница нашей Олимпиады, да?
Добрый вечер. Я из Кабардино-Балкарии, студентка 5-го курса, лечебное дело. Как Альберт Акрамович сказал, победительница международной олимпиады по нейрохирургии, которая проходила в федеральном центре. Очень рада была посетить такого рода мероприятия. Эти мастер-классы очень важны для нашего дальнейшего развития. Отдельную благодарность хочу выразить организаторам Анна Бутурина, Алия, Юрий Якимов и все остальные, которые в этом участвовали. Очень все организовано, и благодаря именно вам хочется снова и снова возвращаться сюда, потому что мы всегда знаем, что будет нам оказан теплый прием в любом случае. Спасибо вам.
Удачи. Олег Титов.
Добрый вечер. Меня зовут Олег, я из Москвы, 6-й курс студент, первый мед. Коллеги, огромное спасибо за предоставленную возможность. Это уникальный и потрясающий мастер-класс. Основание черепа – это космос. И одним из показателей того, насколько это классное мероприятие, является то, что люди приезжают сюда в свой день рождения. Пользуясь случаем, я хочу поздравить коллегу, вот Елена Рыжкова. Вот, у нее сегодня такой праздник. Спасибо еще раз огромное.
Спасибо, удачи. Так, ну, вы знаете, аудитория нашего курса, она очень значительно расширяется с каждым годом. В этот раз, благодаря усилиям нашей бразильской бригады, в частности, почетного профессора Сеченовского университета, профессора Борбы, у нас приехала очень большая группа резидентов из Бразилии. Поэтому я тоже хочу отдельно их дать им сертификаты участия. Предоставить слово. Ричард Гиакамелли. Congratulations. For you, also for you.
Hello. My name is Richard. I'm a senior resident in Brazil. I just want to thank for do this course, brilliant course, and meet a really great person and professor. Thank you so much.
Thank you. Thank you. Good luck.
Thales Nepomuceno.
My name is Thales. I'm a fifth-year resident from Brazil. I'd like to thank for this wonderful center and all the professors for this course and the opportunity to come and learn here in this wonderful country that I come from the first time.
Thank you.
Bernardo Mendonça.
My name is Bernardo. I'm senior resident from Brazil too.
I think I had great times here in Russia. I'd like to thank all the professors, especially Professor Albert and Professor Borba, and so many learnings and fun here. Thank you. Спасибо. Muito obrigado.
Thank you. Bernardo.
Rafael.
So, I'm Rafael. I'm third year resident in Brazil, in São Paulo. I like the invitation. Congratulations for the course and the good organization for the course.
Thank you. Thank you.
Wellington Souza.
My name is Wellington. I'm from Brazil. And I'm the resident from the 5th year. And I'm very glad to be here in the city. We were very well received for all the Russian people from Tumen. And I'm in this one city in the heart of the country. So to come here, it was 36 hours, but I would do it many times if it was possible. Thank you very much for the invitation. Thank you very much, Professor Albert. Thank you very much, Professor Borba, and all the professors that help us to improve our knowledge in neurosurgery.
Thank you. Rodolfo Carvalho.
My name is Rodolfo Carvalho. I'm from Brazil. I'm very happy to be here, and thank you for the invitation of the course. It was wonderful, like your country. And thank you, Professor Borba, and all the professors. Thank you.
Good luck.
My name is Thales. I'm from Brazil. I'm a senior resident too. I would like to thank the from Campinas in São Paulo. I'd like to thank all the professors, especially Professor Sufanov and Professor Borba, for this great opportunity. Thanks.
Thank you. Thank you.
Erion Andrade. £500.
Congratulations. Thank you.
My name is Erion. I'm a fourth-year resident of the same hospital that Thales, from Campinas. And first of all, I would like to thank the Brazilian Neurosurgical Society in the name of Professor Borba, and then thank you and all the Russian faculty for the great course and the great opportunity to get to know such a beautiful country and a beautiful hospital. You guys have a great institution, and it's really a pleasure to me to come here for the first time. Because, I would like to come back. Okay, thank you.
So I'd just like to thank you. My name is Felipe. I'm the senior resident. I'm from Belo Horizonte, Minas Gerais. And I think you had such a great time here. It's been a pleasure to have the opportunity to come and visit this beautiful center. We have such a great structure here. And thank also Dr. Borba, who made the international exchange programs a cornerstone of his management. Thank you.
Jordan Moura.
I would like to thank the Professor Boba and Professor Sofianov to make this course possible for us, and I'd like to thank the opportunity to be here and tell that is more than neurosurgical knowledge. It's a life experience unique you can offer to us in this course. Okay, thank you very much.
Thank you, Professor. Targino Neto.
I would like to thank Professor Borba, Professor Albert. It's a real pleasure for me for being here. I'm a last year med student, and for sure I'll come back again. And thank you for that. I'm from Campina Grande in Paraíba. It's a northeast from Brazil. Thank you, Professor.
Look. Eduardo Pereira.
I'd like to thank for the opportunity to be here. My name is Eduardo, from Rio de Janeiro. I'd like to thank for the great hospitality that we had here and for the opportunity to be here from the Society, Dr. Borba.
Good luck. Bruno Sanchez.
My name is Bruno, and I'm a senior resident of neurosurgery in Brazil. And I just say thank Borba and Sofianov for the course. A great time, great beautiful country, wonderful people, and good vodka.
Emanuel Sá. is here, Manuel.
My name is Emmanuel. I'm from Brazil. I want to thank you, Professor Borba, Professor Sufianov, for the great opportunity to be here. It's a unique experience that I will never forget, and I hope that I can repeat it.
Jorge Passos.
My name is Jorge. I'm from Santa Casa of Ribeirão, Brazil. I'm in 50 years resident neurosurgical. And to say thank you so much for the workshop and be here. And I hope you so sorry come back and see you again in Brazil. And thank you.
Too much vodka, né?
Докторами. В частности, вот хочу начать с Мануэля Рамиреса. First time our faculty. Congratulations, Manuel.
My name is Manuel. I'm from Dominican Republic. I think this is my 11th time or 12th, I don't know. Thank you so much, Professor Bolba. Thank you so much. Thanks to Professor Mashkin, Anna, to all the team. I really enjoy every time I'm here. And also, from the participation of Professor Sufianov in the UNESCO Anatomy Committee in Mexico. We bring this present is a handmade model of cervical spine.
Okay,
thank you so much, Professor.
Thank you.
Thank you.
Valery Kachanov.
Огромное спасибо, Альберт Акрамович, Луис. Ваш центр, и вы лично стали большими друзьями не только в профессии, но и по жизни. Я хочу сделать небольшую поправку к своему вчерашнему докладу, когда я сказал, что Альберт Акрамович один из первых приехал в Крым. Он был не один из первых, он был самый первый. Поэтому я желаю этому центру, вам лично, вашей команде, всем друзьям быть всегда первыми. Не 1.1, 1.2, 1.3, а только первыми. Пусть все остальные вас только догоняют. Вот, а вы всегда будете впереди. И даже если иногда кто-то что-то говорит в спину или пытается плюнуть, понимайте, что это от зависти, потому что они сзади, а вы всегда впереди. И видя столько таких молодых сегодня участников, Альберт Акрамович, резидентов, интернов, вот, 1-го, 2-го, 5-го года, я вижу, что бессмертие будет нейрохирургической службы Тюмени и Бразилии, потому что молодежь идет, и даже с Крыма студенты наши 4-5 курса, вы знаете, участвуют в олимпиадах и занимают призовые места. Поэтому не только уже маститые, убеленные сединами врачи приезжают, но и едет молодежь медицинских университетов. Это гарантия бессмертия вашего центра. Я вам желаю процветания.
Eu caí Ciradinho.
Сиразидин. Congratulations.
Ciradinho?
Thank you everybody for this lovely workshop. Actually, when Professor Sofyanov called me for the first time to participate from Qatar. So I'm the head of neurosurgery department in Qatar, which is in the Middle East. So when Professor Sofyanov called me for the first time, and he said from Tumen, I was like, where's Tumen? So then afterward, I knew where's Tumen, and I came here, and I'm glad that I came here. It was a lovely course and workshop, and I enjoyed meeting with everybody. Like we had people from all over Russia, so that's really a great pleasure for me to be here for the first time, and we'll continue to have the collaboration. Sure.
Okay. Thank you. Thank you. Good luck.
I'm Walid from Kuwait. Prof. Albert, thank you so much. Prof. Borba, I'd like to thank your whole team. Anna, Ms. Aliyah, and all your residents, they've all been very welcoming. Thank you so much. And to the Brazilian team, thank you all. We had a blast. Hope to visit again.
Thank you. Thank you. Abida Shah.
Abida Shah.
I'm Dr. Abida from Mumbai, India. It is my honor and my pleasure to be here, and thank you for the invitation, Professor Sufyanov. You have been great. The course has been wonderful, and your team has been great. It's a great event and great organization. Thank you very much.
Thank you very much. Good luck. Good wishes to Professor Atul Goel, okay? And invite him next time, together. Old friend, old guy.
So it's my fourth time here, and I see this hospital like you see a little kid. Each time that you see it grows, and that's how I feel. And I feel for this place. I thank you very much, Professor Sufyanov, and all the other team, and Dr. Borba for being here in Russia. Without you, we would not have this opportunity. Thank you very much.
Thank you. Hope see you next June.
Okay.
Okay.
Roberto Leal.
Like movie star now. You are like a movie star. Please, some comment. No, I'm not a movie star.
Like a movie star. Like a movie star.
I'm not a movie star. No, I'm just but the point is, no, I'd like to thank you, but not only you, no, all the people that I know here, no, my colleagues, no, doctors and residents, everybody, no, and also the people that works here, no, that I had the contact, no. It was an honor to me, a pleasure to know you and everyone, no, because no, I could see no honesty and no happiness and no everything of good things in the people. So I'm very pleased to be here. It's an honor to me. No, thank you very much. No, and thank your Dr. Barber too.
I hope for collaboration in the future, okay?
Okay, okay.
No last time, so
yes,
next.
no doubt, no doubt, no. I can do that, no. Thank you very much.
It's almost Russian now.
I know. This is a Russian Kazakh.
My name is Marcio. I'm from São Paulo, Brazil. This is my 6th time here. I want to thank Professor Sufianov and Professor Borba, and also thank all the team of the hospital, Marat, Yuri, all the neurosurgeons and residents that help us during this course, give us all the support in the OR, in the lab, and you can see they are really working very hard to make this a good course. And a special thanks to Anna and Alia for making everything possible too. I don't know if this would be the same if you didn't work as hard as you both work to put all these guys here together from all over the world. So I want to thank all of you for your interest in learning skull base. I think it's very important to have surgeons doing old school skull base, and the way to do it is to practice in the lab and train anatomy a lot. So I also congratulate your interest in coming here to learn.
Good luck. Good luck. I am Benedito Colli from Ribeirão Preto, São Paulo, Brazil. I work in a public hospital like this hospital, and for me it's a great pleasure to be here and see how would the things improve when somebody is taking care of this. And this is my 3rd time here. And I would like to thank everybody for being very well received every time. Thank you, Professor Sufianov, and for all your team. Thank you, Professor Borba.
Good luck.
Good luck.
Carlos Eduardo da Silva.
Thank you so much, Professor Sufianov. Thank you so much, Professor Borba, for the opportunity to be here. This is my 3rd time. Thank you so much for the participants. You are the reason for our work here. Thank you so much for your efforts to learn and understand skull-base surgery. Thank you so much for the staff, all our friends that organize everything here. You are wonderful. Thank you so much.
Carlos have very great son. Good wishes to son from Russian neurosurgeons, okay? Good wishes.
Thank you. Vladimir.
Vladimir.
Brazilian Putin.
Yeah.
Always like that, no? Take care of it.
Please, please.
Much, Professor Sufianov. Thank you so much, Professor, my mentor, Dr. Luis Borba. Through time in Tumen, it's beautiful city, and great hospital, and great, wonderful course, and the big school in school-based surgery. Thank you. Thank you, everyone.
Thank you very much. Good luck.
Koji Tanaka. Brazilian Japanese. Mix, Brazilian Japanese. They have Kazakh, now have Japanese.
Okay, it's my first time here in Russia. Yes, in this hospital. I was very impressed with your hospital, your town, your country. Yes, my first time here in Russia. I want to thank you very much for your team, your residents, your staff, Ilya, Anna, everybody that that works to be to permit successes of this course. I hope to come back here again, and to thank you so much for your kind reception again. Thank you so much.
Thank you. Joel Aguilar.
Yeah, I'm Joel Aguilar. I'm neurosurgeon young from Peru, Lima, Peru. Thank you for the invitation in this great course, Professor Sufianov. Thank you so much, and it's in special for the invitation of Professor Borba. Thank you very much, Professor.
Artur Nicolato.
I have to thank you, Professor Albert Sufianov and Professor Borba. It's my third time here, and for me it's a great honor to participate of this course. Every time I come, I get more impressed with the center and the compromise of the center in share knowledge to improve treatment of our patients that are the reason of our work, of our existence. And Professor Sufianov and Professor Borba are very compromised in this kind of knowledge sharing, and for me it's a great honor to participate with this.
Good luck. Good luck.
Thank you, Professor Borba, for the invitation. Thank you, Professor Sufianov, for allowing me to be here. It's an honor to me to be here. I must congratulate you because I'm very impressed. It's my first time in Russia, in Germany, and I'm very impressed with the institution that you created here. I'm sure this is one of the biggest centers of neurosurgery training and courses in the world. You have one of the best labs that I've ever seen. So I think this is very important, not only for the Russian surgery, for the Eastern Europe or the Asian neurosurgery. I'm sure that the work that you are doing here is important for the world neurosurgery. So congratulate you.
Thank you very much.
Thank you for the whole team also, for the residents and so on.
Good luck.
Professor Suvianov, why would you like to impress us so much? No, just why would you like you to impress us too much? So much. Because everybody is very impressed.
Because I have strong team.
Yeah.
Only one man is not possible.
Yeah.
All team like one man.
Work together.
Like one man. This is very important.
Just kidding.
Okay, and now it's a very important moment for me, for our staff, for all participants in this conference now. I want to give my congratulations and certificate to my brother, Professor Luis Borba. Honored Professor of Sechenov University.
Thank you very much. Thanks, everybody. Every day is better. I hope next year will be much better than this one. See you next year. Thank you. Thank you all. Who else is missing? Now for the man that make everything possible. Professor Albert Sufianov. Thank you.
Thank you. Thank you. No limit in dream. All dream possible to organize. No problem. All his Russian. На самом деле, учился очень впечатляющий курс, мне тоже очень понравился. Я много общался с участниками. Всем понравился. Очень серьезный курс. Вот, ну все, когда-то кончается. Поэтому сегодня заключительный день. Мы получили сертификаты. На самом деле, вот доводим лабораторию до идеала. Идеала, конечно, никогда не будет, но мы стараемся. Поэтому я надеюсь, что и на следующий год у нас будут какие-то такие усовершенствования, которые сделают нашу работу еще лучше, наши курсы еще лучше. Я на это очень сильно надеюсь. Приглашаем вас на следующий год. Смотрите наши сайты. Там есть много информации, где, что, когда будет осуществляться. Я надеюсь, что мы сохраним такой же сильный лекторский состав, как у нас это традиционно бывает. И это вот очень важно, не уронить планку. Вот, поэтому надеюсь. Поэтому я думаю, что профессор Борба поможет мне в этом. И не только, скажем, этот состав, но я думаю, что мы привлечем все новых и новых лекторов. So more and more faculty, great faculty around the world. I want to invite organize this one. Okay? Okay. I congratulate with the course, and now I think maybe photo. Yeah? Now photo. Come here.
Global meeting.
next quarter will be glad. Who is glad? Because it's pretty cool. Yeah. А? А я забыл.
Люди в черном? Man in Black? Man in Black.
Передать очки? Вот сюда, вот.
Dear friends, we're now kindly inviting you to go downstairs for having our final meal. And after that, the buses will be waiting for lectors and Brazilian residents at the entrance of the Federal Neurosurgery Center to take you to your evening activities. So I would like to remind you, don't forget to return your devices for simultaneous translation. It's very important for us. Thank you in advance. And I wish you to have a good evening.
Все, вроде